So, as Dr. Santosh Honabar sir is there, one of my teacher. So, I just choose this because in earlier, earlier 20 years back, 25 years back, oculoplasty means it is a minority. DCT, DCR and entropion, nothing. There's a entropion and ectropion, DCT, DCR and Calagian, that's say it was minority. I always oppose. It is not a OT, is a OT number, either 1, 2, 3, whatever, maybe a 10. We cannot accept it is a minority. It's a measure always. Even in DCR also a majority. That's why I choose two topics which can motivate our youngsters. So that is a sometimes now it is in a present era there is a role of exenteration is very limited, but unfortunately in few part of our country still due to the lack of knowledge, lack of infrastructure, lots of patients are in advanced stage. In such cases we may need exenteration, and maximum time it was done in the hand of plastic surgeon or with the help of ENT surgeons. People are generally in general concept they are not think for we cannot go beyond lead. So once it is inside the so much of involvement, so we should not go, but we can also go with this. I will highlight it. So it is a there is a airdrop. Why it is a airdrop? So temporalis muscle helps to disfigurement is one of the issues. I will not go for too much of theoretical point. So is a orbit and execution is a very crucial part of our facial expression, and it is a big culprit. There is so many options in our hand. Theoretically, I will not go. So temporalis is one of the best. I feel it is. I will explain. So this is our culprit. It was done by in the hand of plastic surgeons or sometimes in ENT surgeons, and with combination that's may horror look. What to do? It is a nicely healed ground, but it is that look is not acceptable. So in such cases, temporalis muscle only plays a one of the important role. So it is a airdrop kind of thing. It may be a two-way process. One is supraorbital above the, and one is transorbital, which is a very acceptable one from cosmetic point of view. In such cases is a airdrop in helicopter. There is a soldier, there is a in the Nariman house. If you look during that Mumbai attack, on ground there are lots of casualties, but in the Nariman house there is a less casualties, more results. So that's why I name it as a airdrop technique. So here it is a this is the diagrammatic representation of this. So I generally prefer transorbital. We can make a rim or we can cut the rim, and so there should not be any more bulk here. So a little bit about the anatomy. Everyone knows, I will not go for this. So before that first we can do a exenteration. Moment we can finish the exenteration, we can make a surface marking of this. So in that surface marking, video is not working, I think. Video to hai. हाँ yes. ये हाँ it's not work going. मेरा लैपटॉप लगाना ही ठीक होगा. Or I can start from my laptop. T-shape incision. You can go to the next slide then. You have to play. So then play, again play. Play, yes. So then the play. We can prepare then that one, and we can osteotomy. We can make that osteotomy. Moment we can just make the osteotomy. That my assistant can perform that to save the time. Then that lateral bony removal of the bone, or we can make the window simultaneously, and we can prepare the muscular flap. Next. Once you can finish everything, then you can remove the rim. Next. Then we can just behind that one rim, muscular rim, we can just pass that everything towards the next video. We can pass it, and we can place it in that socket, in the bony socket above that. And then with that breathing vascularization, everything will be there, and we just replace it. Next. Yes, and it should be free. There should not be any necrosis on that, and it should be adequate bony opening, and it should be free. Next. Then once we can secure the flap, then we can go for to raw area. That raw area we should cover by a skin grafting. Next, that everyone knows that skin grafting. Next video, then we can prepare with a skin, and then we can measure it, and we can just replace it. Next. Then of course this is a very essential to placement of the drainage tube. Placement of the drainage tube is essential to any collection. It may be a source of infection, or it may be a cause of non-healing, or some other causes dead. But it is a pedicle kind of graft, so with a proper vascularity, if there is no such necrosis, it will works good. Then the next option is that moment we can place, we can finalize the thing, and final closing is very cosmetically very acceptable one. After that, we can stop. You can stop. You can just search my one now. So this is the final appearance, and with the drainage tube, then after few months, 1 month, 2 months, it may heal properly. Once it's healed, we can go for options in our hand. We can go for a cosmetic mount, or it is a simple plastic also. But that we can avoid the horror look, that hollow appearance we can avoid. Moment he can remove the spectacle, we can achieve all. This is in case of a very important things. Thank you.
Thank you, sir. Sir, any comments, sir? Santosh, sir?
Very well presented. Yeah. Very nice videos.
Thank you, everyone. Our judges, chairperson, and panelists. Now we are running late, so we are going to start next session. May I request Dr. Ajit Kumar Dwivedi, please moderate this session. And may I request the chairperson, Dr. Kian Tiwari sir, Dr. Sunil Singh sir, Dr. Jakke Das sir, Dr. Shahid Alam, Dr. Asif, and panelists Dr. Kunal Kumar, Dr. Ranjan Kumar Rai sir, Dr. K. Agarwal, Dr. Ajay Bhardwaj sir, Dr. Ajit Pradar, and convener Dr. Punendu Sekhar and Pinky Kumari. मैं रिक्वेस्ट सुभाष सर, आपको जाना है सर, आप आ जाइए सर चेयर प्लीज प्लीज सर.
Breakfast is still available. Those who have not had breakfast, please have breakfast. There's a trade area also, which we encourage you to please visit the trade area also. And just as a word of caution, there appears to be conjunctivitis among few delegates, not only one, few. So be careful, try not to shake hands, use...
So good morning and
Thank you.
very warm welcome to BOS MTC at very at very international. Chairpersons already invited. So now we will start the session with a keynote address, and this is my privilege. This is my privilege to call Dr. Santosh Kumar Honawar sir for the keynote address, and he is among us. He has come from a long distance, and he is just visiting us for blessing us so many times. We are very much grateful to him, and this keynote address will be the topic in what is new in retinoblastoma 2024. Please, sir.
Thank you so much. I thank you for the opportunity. Can I have my slides, please? All right. Enhanced TTD because laser would not take otherwise in a atrophic scar. What is also new is plaque brachytherapy, not the procedure itself, but the new Indian plaque. This has made plaque accessible to most of the ocular oncologists at 5% of the cost of the imported plaque. Chemotherapy brought about a paradigm change in the management of retinoblastoma. We used intravenous chemotherapy. It works by 3 mechanisms. One is that it reduces the tumor size to a much smaller scar. This is not possible with any other treatment modality except chemotherapy, because chemotherapy takes you back in time, reduces the volume of the tumor, and the ultimate scar that is produced is much smaller than the tumor that you began with, thus maximizing visual potential. That is one mechanism. The second mechanism is that the tumor always regresses towards its source of blood supply. It always hangs on to its source of blood supply. Example is this tumor where the supratemporal arcade is the source of blood supply. The tumor is abutting the fovea at the initial presentation. Look at what happens after 3 cycles. Fovea is absolutely clear and healthy, and the tumor has moved towards its source of blood supply, which is the supratemporal arcade. So in a posterior polar tumor where visual acuity is crucial, this particular modality helps in taking the tumor away from fovea macula, thereby maximizing visual potential. Intravenous chemotherapy is still the standard of care in India because of cost concerns, but we have evolution in the way chemotherapy is delivered. We have intra-arterial chemotherapy, we have periocular injectables and drug delivery system. We also have intraocular chemotherapy into the vitreous and also into the anterior chamber. For intra-arterial chemotherapy, we typically use 3 drugs to reduce the number of cycles: topotecan, melphalan and etoposide, and then the access to the ophthalmic artery is given by the interventional neuroradiologist, following which we simply have to inject a set of 3 drugs in a very methodical fashion. It has to be a pulsatile injection, and then the effect is very dramatic. This large tumor with total retinal detachment settles down beautifully with 2 or 3 cycles. Similar is the situation. So the effect of intraarterial chemotherapy, especially in group D and E retinoblastoma, is more pronounced, and we may end up saving about 10 to 15% more eyes in group D and E retinoblastoma specifically if you were to use intraarterial chemotherapy as opposed to intravenous chemotherapy. Role of IAC in recurrent retinoblastoma is also proven. This is a recurrence of retinoblastoma over a calcific scar, completely resolved with intraarterial chemotherapy. So it is the standard of care currently in the West, and in India we have all the facilities, but we can't use it in all the children, mainly because of cost concerns. The last bit is about vitreous seeds. Vitreous seeds were always the bugbear in the management of retinoblastoma. We had nothing else to do except external beam radiation. Now we have a lot of advances in intraocular seeds. We don't call them vitreous seeds anyway, we call them intraocular seeds now. We have a classification. There are classic vitreous seeds, there are prehyaloid, subhyaloid, epiretinal, intraretinal and subretinal seeds, each of which can be treated with targeted kind of chemotherapy. And finally, intracameral, which is in the anterior chamber, could be depository. The seeds from the vitreous walk into the anterior chamber through the zonules and get deposited in the anterior chamber, or infiltrative, which come by contiguous extension through the ciliary body, peripheral iris and into the anterior chamber. Classic vitreous seeds, these are prehyaloid seeds, these are subhyaloid, epiretinal, intraretinal and subretinal seeds. And these are the anterior chamber seeds which are depository, and that is infiltrative anterior chamber seed with a D-shaped pupil indicating that the iris is already infiltrated. Now, morphological classification is dust, cloud and sphere as the name indicates, and of course the mixed pattern. How do we treat them? Intravitreal chemotherapy is the treatment of choice for intravitreal seeds, mainly the seeds which remain after the retinal tumor has nearly regressed. So the first management modality is of course to treat the retinal tumor optimally with whatever form of chemotherapy, intravenous or intraarterial, and then whatever seeds that are remaining, those are to be taken care of by intravitreal chemotherapy. You don't do this for the concerns of safety when the retinal tumor is highly active. Melphalan was the drug of choice, but as we started using more and more melphalan, we realized that it causes retinal pigment epithelial atrophy, thus precluding good vision. Then we shifted on to intravitreal topotecan, which is a much friendly drug to the retina. It is used in a laid-back 3-weekly protocol as opposed to melphalan, which is used weekly. And all you need is about 2 to 6 injections of intravitreal topotecan to take care of the vitreous seeds. You can see vitreous seeds nicely calcified. It is very highly effective, but in patients where there is refractoriness to intravitreal topotecan, we can add a low dose melphalan. You can see this patient had, after 6 injections of topotecan, residual vitreous seeds which responded nicely to addition of melphalan in a low dose, thus minimizing the risk of complications. Now, for anterior chamber seeds which were earlier enucleated, we use intracameral chemotherapy. Intracameral topotecan 5 microgram is necessary for anterior chamber seeds, which very gently go away after about 3 to 4 injections. And for those which have a combined mechanism of anterior segment infiltration and intracameral seeds, we use plaque brachytherapy for the ciliary body component, and for the anterior chamber seeds we use intracameral chemotherapy. So most of the eyes with retinoblastoma can currently be salvaged. For epiretinal and intraretinal seeds, we can still use intravitreal chemotherapy. For enucleation, I would just want to stress on adjuvant chemotherapy. The role of adjuvant chemotherapy is real. It can reduce the rate of mortality from 24 to 4%, thus giving you a higher survival by 20% just by identification of these risk factors and adjuvant chemotherapy. For orbital retinoblastoma, which is either primary or secondary, there used to be orbital exenteration as the only modality of management. Now we use multimodality treatment. which means that for the orbital component, we initiate the child with neoadjuvant chemotherapy. Once that resolves and the eye goes into phthisis, we do a enucleation with a long optic nerve stump, then follow it up with stereotactic radiation targeted to the orbit, and then adjuvant chemotherapy. This is a year-long treatment, but the advantage is that the optic nerve extension, which was earlier unresectable, now goes away completely, thus making it safe for enucleation. Intracranial extension also resolves beautifully well. This patient had cavernous sinus involvement. That's gone, and all that is left is in the superior orbital fissure, which is amenable to stereotactic radiation. And of course, cosmesis is a big bonus. These children don't have to use orbital exentration anymore. They can actually undergo an extended enucleation and they get a nice looking prosthesis. This patient had eyelid involvement, and you can see how nicely the eyelid has settled down without needing any surgical intervention at all. Obviously, for the eyelid and of eye was enucleated. Orbital RB also now has a cure. With all this put together, currently survival in India in institutes at least ranges from about 95 to 97%. Still we lose about 2 to 3% of patients for various reasons, especially late or delayed presentation. Most of the protocols that I described are cost effective, are available in India, and are easily accessible through oncologists with whom we should collaborate. Thank you so much.
Thank you, sir, for some enlightenment keynote address, and we get enriched every time when you come to us. And now I invite Dr. J.K. Das, sir, Dr. Jain Kumar Das, and when we need retinoblastoma, other situations are there, we need to remove the eyeball. So there is a eviscerations. We will talk about corneal sparing technique of evisceration. And definitely there is a demand for cosmesis nowadays from each and from our patients. And if you are taking care of that cosmesis right from the in the beginning itself, it will create a lot of support, lot of improved cosmesis in a later period, while providing prosthesis and other issues. Dr. Jain Kumar Das, sir.
Cornea sparing technique of evisceration, a transformative strategy for addressing psychological trauma. In most of the time, especially in accident and emergency, if we say it is not possible to save the eye after 7 days, or initial now protocol is that whatever the wound of extent or injury we can try to repair, we can wait. But there is still one query: is there any sense of endophthalmitis in the other eye? So, but as per such recent data, it is very, very rare, but still there is some options. So if that patient need, anyway that patient will go for a tricycle eye within a 6 months, in such situation what to do, specifically in young. So standard evisceration, of course, it is a good, with a custom-made prosthesis we can provide very beautiful, but still centration is one of the issues. Now there is a recent approach is that by PR surgeon, they are doing ab interno evisceration. That means with a vitrector, if that corneal status is good, they can repair it and they can remove everything, and we can implant a silicone oil inside. This is in like a, on that line. If you think as an oculoplastic surgeon in a some setup, accident emergency setup where microscope is not available, PR instrument is not available, in such scenario is one of the options is this, we can go ahead. The loss of eyeball has a psychological impact requiring we may go ahead with that one, is with very, very easily we can address it. our goal in case of a evisceration, whatever the everywhere we can go one by one. So, but we can provide functionally acceptable, cosmetically acceptable, but psychology, is it acceptable in a young, especially in lady or whatever boy? So in a college students is not possible. So to for a moral boost up in that such cases, and on the other hand, following the evisceration, there may be some issues. There may be a sulcus defect because there may be a lead anomalies, etc. Because we removed some part, we can sacrifice the cornea at least, and to protect exposure, extrusion, etc. There is some other issues. If we want to implant, generally we need a implant of 20 mm size, which is not possible. There is a chances of migration, there is a chances of extrusion, etc. is very, very high. To overcome all those things, I will calculate everything in what are the other parameters we can take care by this process. Goal of this procedure is well-centered orbit implant. So in here, that as whole the cornea and sclera is in there, so you can well-centered, is 100% well-centered, and chances of extrusion, exposure are almost nil. And the socket lined by both the cornea as well as the sclera. But it is one of the difficulties is that it is taken lots of times. Surgical steps are corneal steps. One is conjunctival tenon and disinsertion of the muscle. With this technique, I just train my two juniors. One is in cornea, one is who is doing squint. Reason is that there is a corneal step is that, as we know that for that sympathetic ophthalmia, the main culprit is the endothelium. So here I just remove all the endothelium in nice way. Generally I ask my junior cornea consultant to do this. So they are like in dissect, they are doing this step. This is a learning curve for them. And if there is any squint surgeon or myself, I am trying for the squint surgery also. So because it needs a disinsertion of the superior rectus and superior oblique muscle to implant the ball, and through the superior sclera we just remove, we can perform the surgery. So this is one of the big advantage in institute. So we can teach our junior colleagues for dissect. Simultaneously, we can ask them to do for a fellows, we can teach them for a squint surgery also. So rest of the steps are, one is scleral opening, and evisceration is not through a corneal button, evisceration through a scleral cut. This is one of the little difficult for a oculoplastic surgeon. Of course, we can perform. Then, as I already mentioned, well-centered orbital implant is very, very important, and closing is little. It takes less time because there is a less amount of cut, is not a 360-degree cut, and moreover there is we can preserve the ocular surface whole. There is no need for any injury in the limbal stem cell. That's a very, very beauty. So for post-socket related, other related, prosthesis related complications are very, very low here. What are the corneal steps? As I already mentioned, one is dissect kind of decimates stripping of endothelium like a endothelial keratoplasty. Then epithelium, we should remove the epithelium by absolute alcohol. It is a little easier. We can de-epithelize the whole cornea by 100% absolute alcohol. Steps on extraocular muscle. The junior colleague squint surgeon can do this, and if that video works, then I can just so here, okay, I'll show that video later on. Okay, so, yes, come here. Oh, I want to, so what psychological impact? First up, we can move a 360-degree, is that possible? Fast forward. So we can make above that there is a 120-degree more or less, 110 to 120-degree conjunctival opening. Then we can first identify the muscles, superior rectus and superior oblique. We can disinsert the superior rectus and superior oblique, and it is basically a traumatized eye. It is this patient, it is almost traumatized. There is a rupture of the sclera. So then we can identify about that. We can identify the muscles, superior rectus. Moment we can, then we can disinsert the muscle. Then once we can disinsert the superior rectus and superior oblique, we can just go for a opening above. So both the muscles, that wound will be covered by lateral muscle, then tendons, and the conjunctiva is well secured. But one of the difficulties is that is like a kind of a indirect, is not a, is after the epithelialization cornea become almost high. Yes. This boy, he was with a high hope. He was undergone PR surgery. There's a silicone oil inside, but it was not possible. Following trauma, there is a RD. There is so many things, and there is a twice PR surgery was done. So there is a lots of adhesion, but still we can perform slowly. And we can remove. Moment we can remove, then rest of the thing, that ball we can implant inside. So yes, but in a twice post-vitrectomized eye, PL negative following injury. So is little difficult in such cases to remove the eviscerated material, but in a fresh wound it is very, very easy. Then once we can clean it, everything, then we can insert the ball inside, and we can close the wound by sclera, then we can layer by layer we can close. This is why. So what are the benefits? Is a small incision, is not a 360-degree incision. Generally with your expertise you can reduce it up to 100-degree also. So just a disinsert, I just disinsert superior rectus, superior oblique, because there is a for extra cover. So it's behind. Little difficult, but intra, all intact coats, all coats extra, that ocular coats are, and that is a guaranteed is 100% placement in central placement. Disadvantage is long surgical procedure, long learning curve, chances of corneal and corneal-related disease. As that cornea, I'll speak up within a minute. That's why, and it is a comparable with the ab interno evisceration. With the standard, it is the all complications. I don't go for, but calculation I want to say why. Globe volume is 8 ml as per the Colin and Rose. It is, if we implant at least for 18 mm, then only we can 3 to 4 ml we can add. But there is a volume for cornea is 1 ml. So that 1 ml we can reserve. If we implant 18 mm, we can, in a fresh case, we can implant 18 mm. So 4 ml already they are out of 8. By rest of the thing we can taken care by prosthesis. So this is the, and this is the one of the my patient, young boy. Yes, if that video is working.
Sir, we are running short of time.
Yes. Just I want to just show the appearance. Okay. Motility is very, very excellent. Thank you.
Thank you, sir.
Thank you, sir. And now I invite Dr. Devkan for his presentation on occult foreign body in ocular and periocular area, challenge to decide site of incision for easy removal. In the meantime, we can take one question.
May I request Ranjan Kumar Rai, sir, so please come on dais, sir, and Dr. Kunal Kumar. Sir, please. Sir, please.
Just a small question by the time he gets ready. Like many a times you said that it's like a traumatic cases where we are doing the evisceration, eye with high
Sir, you can come to the other panel.
So in such case, So in such cases, like basically, when we put an implant and you need a squirrel shell later, does the corneal sensation hamper many a times? Because this is what I have seen, that sometimes the corneal sensation hampers putting a squirrel shell or a shell later.
That's why here we are doing deepithelialization, complete deepithelialization of the cornea. Cornea sensation is deepithelialization once, and second is we can just strip that endothelium also. And the reason is that we can prevent sympathetic ophthalmia. Once we can 100% deepithelialize, there is a ultimately there's a conjunctivitation of the thing, and there's the same tissues it will cover. It will be a total opaque, and sensation will be very, very less in such cases.
Thank
That's the way. So it is not
Thank-
possible 100% because 100% deepithelialization may not be possible on maths, but it is more or less it can be done.
We are,
That's the point 2 point.
please, sir. We are running, sir. Dr. Devkan, please talk on occult foreign body.
Good morning, everyone. I am going to share my experience with occult foreign body in ocular and periocular area. Occult foreign body sometimes challenge to locate to decide site of incision for minimal iatrogenic damage to our vital structures. And usually it encounters mostly after penetrating trauma, which accounts for 30 to 50% of all our vital injuries. To weigh the risk of surgery against the risk of retention, determination of type, location of foreign body are important. This is just a start with the case scenario. This is a case of which has presented to me with actually this 4-year-old child referred to me for removal of residual glass piece with history of trauma at inner canthus after fall over glass bulb. On examination, there was vertical linear scar and discharging sinus tract were noted in the lacrimal sac area. NCCT orbit was suggestive of linear hyperdense foreign body along the medial canthus of left eye in close relation to lacrimal sac. This is the way how I have managed. Actually, I could not decide at what start I should, at what area I should start with start incision. So I taken 15-degree surgical blade and moved over in saving fashion over the suspected area of his skin. Then foreign body was felt with edge as a stop and filling of glass with a knife blindly as the blind uses his stick. But vertical incision was given just over the edge of the foreign body, and blunt dissection carried up to and around it. Foreign body was pulled with serrated forceps for the best hold. Because it was glass piece, so I used and it was very much friable. So with the toothed forceps, it was not holding. So I used serrated forceps. This is another case which is 10-year-old child referred to me with swelling and restricted ocular movement after removal of wooden foreign body following trauma by bamboo stick 2 weeks before. On inspection, there was localized hard mass below the lower lid with mild edema, chemosis, conjunctival congestion, and painful restricted ocular motility. On palpation, there was hard mass felt just under the lower lid. This is the way how I have removed. I just pull the lid down below the maximum bulge with finger, and fornix was depressed with bud. Wooden foreign body was found which was extruded with pressure and removed with ear bud during examination only. This is the third case. 45-year male from remote area presented with pain, foreign body sensation, and loss of vision with history of something gone in eye while working with chisel and hammer 1 month before. On examination, self-cell corneal perforation with iris prolapse and were noted with surrounding stromal edema and total cataract. NCCT was suggestive of foreign body in anterior part of the globe. This is the way how I have managed. The side port was made just near the entry wound in view of easy manipulation of foreign body, because this is the area where through which the foreign body has gone inside. The foreign body was felt with iris repositor and removed with micro holding forceps through the other side port, which was made in long direction of foreign body. For successful management, complete history about the mechanism of injury and nature of the foreign body and full examination recommended to rule out globe rupture, optic neuropathy, detection and determination of material along with location of foreign body is important for expected complication and plan of management. CT is imaging modality of choice for detection, extension, and to distinguish material of foreign body and fluid collection in case of suspected abscess. To visualize glass and plastic fragments embedded in muscular tissue or in close proximity to bone, it can be done through the three-dimensional reconstruction, but CT may produce false negative result in case of wooden object of size 0.5 mm. MRI is reserved for highly suspicious organic material or fragment that are less than 0.5 mm on CT. Its limitation is it cannot do, you cannot prescribe MRI if there is suspicion of metallic foreign body. We will have to exclude it either through the history and plain X-ray. Ultrasonography foreign body appear as high reflective echo with back shadowing, but its limitation is that interpretation may vary and sometimes foreign body may be missed completely. Moreover, it is relatively contraindicated in suspected globe rupture. Treatment protocol is anti-tetanus prophylaxis according to vaccination status. Appropriate antibiotics. Retained foreign body may lead to infection, inflammatory reaction, granuloma formation, osteomyelitis, nearby soft tissue damage through its migration. Will have to weigh the risk of surgery against the risk of retention, including fistula formation or infection, greatly based on location, size, type of material, morbidity and expertise of surgeon. For occult foreign body exploration through entry site and follow a scar tissue or fistula pathway is recommended. For intraoperative guidance, high frequency ultrasonography, ultrasound with linear transducer of 7.5 to 10 megahertz and a stand-off pad made up of bag of saline filling of globe with ultrasound gel provide better resolution of superficial soft tissue. Continuous X-ray, which is known as fluoroscopy, is also recommended. In our case, we have precisely located occult thin glass piece of subocularis plane of lacrimal sac area with surgical knife. We can call it blind stick technique and removed with serrated forceps.
Kindly conclude.
Extraction of orbital foreign body. Orbital foreign challenge because it is the crowded and complex structure. A small inert deeply located metallic foreign body in orbit are usually managed conservatively with well tolerated if left in place. But the patient should be notified about the chances of abscess or fistula formation, preclude patient from undergoing future MRI if they are ferromagnetic. Indication for removal of foreign body from orbit is when it causes functional damage to subsequent inflammatory complications. Surgical removal may be considered for foreign body located in anterior orbit even in absence of traditional approach is either through a transcutaneous approach or transconjunctival approach through the fornix or through the peripulbar conjunctiva. And imaging modality, new image guided navigation system is there, like InstaTrack, Lander X system, Cygnus PFS system, Stealth system, Fusion ENT navigation system, extraction of occult intraocular
Dr.
foreign
Devkan,
body.
please conclude.
Just 2 minutes. Intraocular foreign body should be through separate limbal incision with using viscoelastic solution. Concurrent intraocular lens insertion is usually not recommended because calculation of power may not be exact, and more chances of postoperative complications such as severe inflammation. In our case, we have located occult iron chip involving iris from anterior chamber with iris repositor and removed with micro holding forceps through separate limbal incision in long axis of foreign body. Posterior chamber intraocular foreign body should be managed by VR surgeon. Conclusion, management of occult foreign bodies should include detailed history, CT scan of orbit, which is the best initial imaging modality. We should plan site of incision over the entry wound and site of easy removal of foreign body. We described basic techniques: see and feel, means inspection and palpation of foreign body with sharp edge of blade or finger or iris repositor and sweeping over suspected area. The blind stick technique as additional guide to mark foreign body intraoperatively to site of incision to minimize damage to adjacent structure. Serrated forceps provide the best hold on a smooth friable foreign body, and micro holding forceps is best for intraocular foreign body. These are my.
Thank you. Thank you, Dr. Devkant. And now I invite Dr. M.S. Ali for monoocular elevation deficit diagnostic and management challenges, and request to stick the time.
Requested to everyone, please adhere to your allocated time.
What's the presentation?
Presentation. Or AV people kindly help him to get the presentation.
I think
You have not.
I uploaded on that system. Thank you.
(11:30) we have the inauguration, and our chief guest is going to be exactly on time at 11:30.
Good morning,
And before
everyone.
that, we have to finish the RHPC inauguration also by Dr. Santosh Anawar. So please be on time.
So I'll be talking on the topic of monoocular elevation deficit. What are the diagnostic and management challenges? So what do you mean by MED or double elevator palsy? There is the limitation of elevation in the one eye due to the paralysis of the superior rectus as well as the inferior oblique. And it is the important finding is that the limitation is both present in the adduction as well as abduction of that eye, and it is also can cause hypertropia and also present with ptosis or pseudotosis. These are some of the cases of monoocular elevation deficits. The first, all these cases are presenting with the ptosis and the hypertropia in one eye, and one case, the last one is there is an abnormal head posture due to the limitation in elevation. So what is the etiology? It can be congenital or acquired. The congenital cases are usually most commonly seen, and it is due to supranuclear palsy, where the primary superior rectus and primary inferior rectus restriction. Acquired cases are due to the trauma like blowout fractures of the floor, the disc thyroid orbitopathy, and the cerebrovascular accidents, and also tumors and other sarcoidosis and syphilis. Now the MED, there are three types. The type 1 has the inferior rectus restriction. Here the forced duction test is positive. In type 2, there is a deficient innervation of the elevator muscles and includes the superior rectus palsy. In the type 3, there is a supranuclear type of disease where the gaze centers are involved, and usually it is congenital in presentation. So this is a video. We can see the right eye is having a ptosis as well as there is limitation of elevation in that eye. Another case presenting with the left eye MED with left eye ptosis and limitation of elevation. This patient is having the same condition, but he has also a jaw winking phenomena present in that. In this case, there is also a Marcus gun jaw winking present. So these are, now there are some cases where which appear as a case of MED, but they are not. That, like this case was this one, the left side. It is the alternate exotropia with the inferior oblique overactions. So it appears as a case of limitation elevation, but it is actually the right eye is going into elevation due to the inferior oblique elevation overaction. The second case is was a case of neurosurgery where there is a dystopia, but there is no squint, and but the ptosis is present, but there is no hypertropia of that eye. So it is not a case of MED. So the features are that can be vertical misalignment of eyes, that there can be diplopia of recent onset, there can be abnormal head posture, and there can be drooping and can be amblyopia also. The signs can be ptosis or pseudotosis. Pseudotosis, we say when if the hypertropic eye takes up fixation, the ptosis is gone, then it is called as a pseudotosis. The strabismus is there, the eye is in hypertropia. Bell's phenomena is usually absent, but can be present in cases of supranuclear defects. Amblyopia can be there, abnormal head postures. The saccades, vertical saccades are to be examined. So now the essential thing is to do a force direction test, active force generation test, and the Worth 4 dot test to assess the binocular status. The differential diagnosis can be a Brown syndrome, the vertical Duan syndrome, Duan retraction syndrome, can be congenital fibrosis, partial third nerve palsy, progressive external ophthalmoplegia, and the orbital inflammatory diseases and orbital cellulitis. Non-surgically management, we should manage the amblyopia and the refractive errors. Surgical management is the mainstay of treatment. We have to keep the eye in the hypertropic eye in the primary gaze. We have to do for that we have to correct the deviation, and these are the indications. If the FDT is positive, then we have to do an inferior rectus recession, and otherwise, if the FDT is negative, then we do a muscle transposition surgeries. So the NAPS procedure is the most common method, most commonly used, where we transport the horizontal recti, that medial rectus and the superior rectus adjacent to the superior rectus, and it can correct deviations up to, it is some variability, but it can correct up to the 40 prism diopters of vertical deviation. Modification of NAPS can be used if there is also horizontal deviation, where we split the muscles, horizontal muscles, and the superior is attached adjacent to the superior rectus, and the inferior part is corrected for the horizontal deviations. Augmented NAPS is also there, and sometimes if there is a risk of anterior segment ischemia, like in old patients or the atherosclerotic disease patients, we can do a modified Disrida's process where there is no disinsertion of the muscle is just pulled up and inserted to the superior rectus. Contralateral superior rectus recession can be done. After we correct the squint, the vertical deviation, we should correct the ptosis, which can be corrected by the levator resection or the frontalis sling. These are some of the cases we have done. So here we first did the NAPS procedure, and then we did a sling surgery to correct and now this final outcome is like this. There is some horizontal deviation still present, which should have been taken care at the time of surgery, but we can proceed for the horizontal surgeries to correct this deviation. Another case so these are some of the cases. Surgical complications are just like other squint surgeries. And to summarize, it is not an uncommon presentation. The MED is not a uncommon presentation. So we have to rule out other causes of vertical deviations. FDT is a must to rule out inferior rectus restriction. And the surgeries are like the NAPS, modified Nishida, and augmented NAPS, and ptosis has to be corrected. The outcomes are not as satisfying as like the horizontal surgeries, but still the patients are satisfied with the outcomes. Thank you for patient hearing.
Thank you, Dr. M.S. Ali. And now I will invite Dr. Sanjay Kumar, the Associate Professor at Nalanda Medical College Hospital. And we know that DCR is a very commonly performed surgery in oculoplasty, and we must know about the nasal aspect. Nasal, we should know the anatomy of the nose. At the same time, there are multiple things which are required during DCRs, or there is another technique, endoscopic DCR, I will talk about in detail. So please, presentation.
Good morning, respected chairperson and audience. Today I am going to share my specialty regarding anatomy, brief anatomy of nose. So regarding anatomy of nose, we are here to discuss or present about the lateral wall of the nasal cavity. So lateral wall of the nasal cavity consisting of this middle turbinates, this middle meatus, and inferior meatus, inferior turbinates, and superior meatus and superior turbinates. Similarly, here you can see there is projection of all the three turbinates and meati. So this inferior meatus is important to facilitate the drainage of nasolacrimal systems. Now coming to endonasal endoscopic dacryocystorhinostomy. So this dacryocystorhinostomy is an indication for the epiphora causing block by the nasolacrimal apparatus at the outflow obstruction of the anatomical as well as functional obstructions of the nasolacrimal apparatus. Under normal conditions, the mucosa of the lacrimal sac is highly resistant to infection. However, infection of the lacrimal duct may develop or triggered by functional problems. Here we can see the anatomical landmark of the lacrimal apparatus. So it is punctum, upper canaliculus, lower canaliculus, common canaliculus, sac, and nasolacrimal duct. This endonasal DCR consisting of 4 steps. First is fastening of the nasal mucosal flap. Second is osteotomy. Third one is opening of the lacrimal sac and the creation of anterior and posterior flap, and manipulation and replacement of the flap, and placement of the siliconized tube sometimes. Indications. We used to do this endonasal endoscopic DCR in pediatric dacryocystitis, adult chronic dacryocystitis, mucocele, pyocele of the lacrimal sac, mucolithiasis of the lacrimal sac, or recurrent dacryocystitis. Prerequisites. We must have X-ray or CT scan to see the anatomical variations of the nose and paranasal sinuses. Probe test. For the endonasal DCR, mostly, and one of the single tests to do is probe test. If you are following probing, if you are feeling or facing soft stop, we are stopping or we are devouring the procedures. Or if you are feeling hard stop, there is indication of endonasal dacryocysto-rhinostomy. Third one is lacrimal scintigraphy is one of the important investigations to see the passage of the nasolacrimal apparatus. Dacryocystogram is other investigation tool to rule out the patency of the nasolacrimal apparatus. Here we can see the different photographs of the mucosal flaps and the bony parts of the frontal process of maxilla and the lacrimal bone, which is bonded anteriorly and posteriorly respectively. Now, following the removal of the bony parts, frontal process of maxilla, here we are able to expose the lacrimal sac. Following exposure of the lacrimal sac, we are dividing the sac or taking incision over the sac or dividing the flap into anterior and posteriors. So advantage of the endonasal endoscopic DCR, it is short operating time, it is aesthetic as well as scarless, less post-operative pain, or we can repeatedly do the endonasal DCR, even 2 to 3 times can be done in the same patient and with low morbidity. Post-op care, irrigation of the nose on the third day of the post-operative third day of the procedures, followed by weekly for 3 to 4 weeks. Gentle syringing and lacrimal massage is the indicated post-operatively. Endoscopic examination to remove the crust and mucosal adhesions. Complications, some orbital cellulitis, ecchymosis, synechia, sometimes orbital fat prolapse can occur. Thank you. Yes.
Do you do CT and PNS in every case before doing endoscopic DCR?
Usually X-ray I used to do.
Okay. Just a suggestion, if you would do a simple endoscopic examination in a OPD, it
Yeah.
would help you.
Yeah.
Because
In every case planning for endonasal endoscopic DCR, we used to do diagnostic nasal endoscopy to rule out sinonasal pathology or any mechanical obstructions.
And second comment, you said if there is a soft stop,
Yeah.
in a chronic dacryocystitis or if there is an encysted mucocele due to the canalicular stenosis, we can get a soft stop in the OPD
That's why.
during probe.
For that purpose only we are not doing this endonasal DCR.
But we can do. After doing that, we can put a mini monocard.
We can do, but for that we have to do that tube placements.
Thank you,
Thank
Dr. Sanjay Kumar, sir,
Thank you
for such a enlightening talk. And now I invite Associate Professor at IGMS from and our dynamic CSC, Dr. Gyan Bhaskar, for a step-by-step external DCR.
Thank you, everyone. In my presentation, nothing is new, but basic thing is how to simply we can perform the DCR. Everyone is feared to do DCR because of unpredictable outcome even after doing the good DCR and intraoperative bleeding. So we are most of the surgeon is referring to the any center कि चलो DCR कहीं और जाके करा लो. Many everyone is know to what we are creating anastomosis between the lacrimal sac and nasal mucosa and creating the bony ostium. Dr. Sanjay has discussed about the anatomy. Before going to the any kind of DCR, either endoscopic or external DCR, we should know the proper anatomy of the nose and the lacrimal apparatus. Then, first of all, you should properly diagnose which type of the cases we are dealing. Either of the dealing with the obstruction of the nasolacrimal duct or canalicular obstruction or canalicular obstruction. Just in the OPD process, OPD, just to press over the sac area, and if there is a regurgitation is positive, then simply we can say there is a nasolacrimal duct obstruction. And other sac irrigation, if there is no regurgitation, then we can confirm with the sac irrigation to know the obstruction, the site of obstruction, then accordingly we can proceed for the DCR. These are the steps from starting from the nasal packing to the wound closure. Every step is very important because we did not do any nasal packing properly, then intraoperative bleeding may cause, or we can difficulty to found the nasal sac. And proper nasal anesthesia is very important. These are the some techniques by which we can ये आगे कैसे बढ़ेगा कोई नहीं. Anesthesia is very important because first we should block the infraorbital nerve. This is the animated version. You can block the also block the infratrochlear nerves, dorsal-nasal branch of the nerve, and then the anterior smiler branch. And this is the video just to see how can we give the proper local anesthesia so that intraoperative the patient is not feel any type of pain. Otherwise, patient is apprehensive regarding the pain, and we should further go for the general anesthesia if patient is highly apprehensive. Increase करने के लिए हरी जी इसको कैसे इसका देखिए तो बढ़ाने के लिए नहीं आ रहा है इसमें ब्लॉक इसमें देखिए तो इसमें ब्लॉक कहाँ से आएगा फुल कर दीजिए ना फुल स्क्रीन फुल कर दीजिए फुल कर दीजिए ना हाँ अब आएगा before after the proper block then we proceed for the surgical procedure. We can start. Marking should be done at the level of the anterior lacrimal crest or 1 to 3 1.5 to 2 centimeter from the millimeter, sorry, from the inner canthus, and blunt dissection is carried out up to the periosteum with the blunt dissection and separation of the orbicular muscle, and we are trying to reach up the anterior lacrimal crest, and this just you see this is the medial pulpal ligament, and it's this is the one landmark, and sac is just behind the medial pulpal ligament. And with the blunt dissection, we try to reach up to the bone and up to the periosteum, and periosteum is divided into two parts, anterior and posterior part, and then sac was dissected along with the periosteal wall so that we cannot damage the sac wall. Just you see at the at the bone, and with the periosteum elevator, we try to dissect the sac, and sac always should be dissected with the periosteum. After that, punctum, after dissection of the sac, punctum dilator should be done, and to with the help of the probe visualize the opening, internal common opening, and the sac wall. Then with the help of the either 11 BP blade number 11 or the with crescent, and with the help of spring scissor. But sometimes we cut partially, there is a partial cut of the sac. So just you see that after the complete cutting of the sac, there is a regurgitation of the sac content, so that we can confirm that we are in right path. With the help of the spring scissor, then we secure the anterior part of the sac wall, and with the secured with the vicryl or 60 vicryl, then posterior wall of the sac we can preserve, or we can There is this is the probe is coming out from the anterior, and just to see the internal common opening. It should be always preserved at any cost. Then after creating the ostium, and with the help of the bone punch, and ostium should be at location in front of the internal common opening and with more than 8 millimeter at least. And shape should be circular over, and the site should be posteriorly at the lamina papyracea, superiorly at or slightly above the level of the medial pulpal ligament, and inferiorly as much as possible. And we can cut the posterior part, and this is the pack, and tenting or anastomosis of the sac wall is done and followed by the reconstruction of the wound in the layers. These are the common complications we can get: annular bend damage or partial cutting, and these are the complication of bleeding or puncture or canonical laceration, and these are the causes of the failure of the DCR. So conclude that proper history should be taken, careful examination is mandatory, and always differentiate either it is we are dealing with the common canonical block or nasolacrimal drug. So plans should be accordingly. Thank you so much.
Thank you so much, sir. And I think moving on the topic, I think we have proximal block. It was a simple procedure for the external DCR. Dr. Kunal Kumar is here, and he will talk about the proximal block of the lacrimal system and how to address them. Dr. Kunal Kumar.
Thank you so much, sir. Good morning, everybody. And till now we had been dealing with the distal end of the block and managing it. Now we are going to talk about the proximal end of the block and how we are going to manage that. So again, the normal anatomy of the lacrimal system. Here we are going to deal only with the proximal part of it, which can be broadly be classified as a punctal and the proximal canalicular block. Now, broadly the proximal canalicular block can be classified as suppurative and non-suppurative. Now, the punctal stenosis can be a congenital malformation where we need to look into the papillae, whether the papillae is present or absent. If the papillae is absent, that signifies that there may be absence of the lacrimal system. With papillae present, it could be chances that there could be a block. So it could be because of various drugs or because of the infections. It could be because of cicatrizing diseases like Stevens-Johnson syndrome, ocular pemphigoid, or chemical injury. Because of the tumors like papilloma, basal cell carcinoma, or iatrogenic damages because of repeated dilatations. So what exactly happens is, if there is an eversion of the eyelid, the fluid does not pass through the lacrimal system. Now, passing of the fluid is important to maintain the lacrimal system. Even after we do a DCR, how does the system maintains is, once the fluid starts passing through the lacrimal system, it doesn't let it block. So if the fluid does not pass, there is a punctal which can lead to punctal stenosis. This in turn leads to tearing. The tears has got enzymes, and this in turn causes contact dermatitis, further exacerbation of the reversion of the eyelid. So incomplete obstruction can be managed by repeated punctal dilatation, or if it doesn't respond to that, we can go for 1 snip, 2 snip, or 3 snip procedure. What is a punctal 1 snip is? We just do a punctal dilatation and we just make a snip on the vertical canaliculus. The 2 snip goes second step where we make a snip on the horizontal canaliculus also. And then a 3 snip is something where we remove the part of the triangular part of it, calling it a 3 snip procedure. But if there is no papillae or there is a complete obstruction, the only option left is a bypass surgery where we do a conjunctivo-dacryocysto-rhinostomy. Now, this can be again because of suppurative or a non-suppurative kind. In a suppurative kind, the commonest is the actinomyces causing the infection, which is what occurs actually is this infection occurs usually in the ampulla, which is the circular dilatation, and both the proximal and the distal end of the ampulla, there is a constriction and the infection proliferates there or it grows over there. So this can be managed by milking of the stone or repeated syringing with antibiotics. If it doesn't work out, we do a canaliculotomy with curettage. The other non-suppurative obstruction can occur because of trachoma, viral infection, various other causes. Now, next we want to go to the DCR, where the commonest procedure over here, commonest in the sense if there's a proximal block and if nothing works out, DCR with a Jones tube can be an option. Now, we had always been looking for an ideal tube. A lot of developments have happened with the tubes. What should be an ideal tube like? Should be straight, should be non-porous, hydrophobic, should be rigid, non-reactive. And various materials have come into use like polyethylene, propylene, silicone, Teflon. But finally what worked out was a Pyrex glass tube called as a Jones tube. It has got ocular flanges. It can be mostly what we have seen is a straight one. The flanges can measure into different sizes. The inner diameter is 1.5 to 1.7. The outer diameter is 2.5. Length is the most important thing, which should not we should be ready with the different lengths, and when we are doing the procedure, when we are doing a DCR, at that point of time we need to measure the length short of 2 millimeter from touching the nasal septum, and that is the length which we should put. Some of the Jones tube also has got a suture holes where we can anchor it on the proximal aspect. So this is a DCR with a Jones tube. The initial process we have seen, Dr. Gyan Bhaskar has shown us the same procedure. We take the incision, we dissect the periosteum. I've run the video fast. The initial part is same up to making the posterior flap. Once we make the posterior flap, then we need to make a place for placement of the Jones tube. So here we remove the caruncle partially so that we make a place for the Jones tube to stay there on the proximal aspect. So we have removed partially the caruncle. We enter from the caruncle into the lacrimal sac. We extend that with the 50 knife. And once the enough space is there, we are suturing the posterior flap. And then we place the Jones tube of appropriate size. Here the Jones tube is gone inside. It has been there, which is seen into the lacrimal sac, in the lacrimal area. We are anchoring anteriorly. We do not have the flanges with a hole. We are anchoring it proximally with a non-absorbable suture. And then we close the anterior flap and we close the wound as we do it in DCR. So what are these are the important precautions what we need to take care of the tube. Most important is some way or the other, most of the time the tube gets displaced. One of the common causes is blowing of the nose or sneezing. So we have seen a lot of failures basically with the Jones tube. And these are the cleaning of the tube and knowledge required. Sometimes a granuloma formation can occur. So there can be a hemorrhage, extrusion of the tube. If there is a blockage, we have a Jones tube which is used for cleaning the tube. I'll just show you a small video of the complication where there is a granuloma which is formed, which has blocked the anterior aspect, the proximal aspect of the tube. We are removing the granuloma. It's a suture granuloma basically. The suture, we are separating the suture, remove the granuloma, and then we clean with the Jones tube, the Jones cleaning tube, and then we do a syringing which can be seen into the nasal cavity. This is a cleaning which is being done. And here we see that the syringing is clear. Thank you. I would also like to acknowledge Shankar Netralia where I took the videos when I was working there. Thank you so much.
Thank you, Dr. Kunal, for explaining such beautifully regarding the proximal tube blockade of lacrimal system. Kindly come to in the meantime we can take question. I invite Dr. Ravi Ranjan sir, and we are talking about so many suppurative kinds of inflammations and types of dacryocystitis. Is it corneal ulcer a cause of dacryocystitis? Dr. Ravi Ranjan Kumar.
Very good morning, off the dash, on the dash delegates. My topic for today is corneal ulcer a cause of dacryocystitis? Of course, it is against the popular belief. No financial interest, no conflict of interest. As you all know, corneal ulcer caused by infection is one of the leading cause of blindness worldwide, second only to the cataracts. And this medical condition is caused by pathogens in India and particularly common in developing countries like India. Pathogens responsible for corneal ulcer can be bacteria, fungi, virus, protozoa, parasites, and it is crucial to raise awareness about this condition as early detection and treatment can prevent vision loss and its consequences. The aim of the study is to explore the prevalence of corneal ulcer with dacrocystitis, and a study design is prospective, where non-control case series with an inclusion of 58 eyes with infective corneal ulcer. Out of 58 patients, right eye 31, left eye 27, and inclusion criteria were patient having corneal ulcer in one eye and no history of any lacrimal pathology. And after the positive diagnosis of corneal ulcer with the syringing of the lacrimal drainage system was carried out before any medical treatments, and lacrimal syringing consisted of punctal dilatation as usual what we do. And the medical treatment of corneal ulcer is initiated based on their clinical and pathogenic diagnosis, and surgical treatment was performed when the infection could not be controlled by medical treatment with the help of corneal specialist. And if there is no progress in the healing of corneal ulcer after 3 to 4 weeks of treatment, we re-examine the nasolacrimal system. And if there are symptoms of dacrocystitis, systemic antibiotic is started for a week. If there is still no improvement, we perform DCR with silicone tube intubation. And the outcome is very satisfactory. After 3 to 4 weeks of DCR, the silicone intubation, the infection was under control and the corneal epithelium healed. These are the few examples. Second one, third, fourth, and so on. The results are among 58 patients, 5 were diagnosed with dacrocystitis at the end of 3 to 4 weeks. And 1 case was successfully treated with medical treatment, while the remaining 4 required DCR. And we conducted this prospective study to explore the possible link between corneal ulcer and dacrocystitis. And only a limited number of published studies indicate a high risk of dacrocystitis due to corneal ulcer. And the prevalence of corneal dacrocystitis in North Indian study, the prevalence of dacrocystitis was 19.5 per 10,000 patients, and the incidence of acquired dacrocystitis was 15 per 10,000 patients in North India. And according to the population-based study conducted by UG MD in North America, the average annual incidence of symptomatic acquired lacrimal outflow obstruction in people above the age of 5 years was found to be 0.03%. Alarmingly, our data shows 8.6% of the eyes with corneal ulcer suffered with dacrocystitis. More importantly, patients in our study had no history of dacrocystitis previously. That is, they were diagnosed with the dacrocystitis from the first time only after 3 to 4 weeks of corneal ulcer. This is the different isolates, and the corneal ulcer can lead to obstruction of the lacrimal duct, particularly in the lower canalicular region, causing dacrocystitis. And to the best of my knowledge, the corneal ulcer can lead to lower canalicular obstruction, while dacrocystitis can worsen corneal ulcer by delaying tear film clearance and altering microbial flora. Although various studies have been conducted on the treatment of dacrocystitis and corneal ulcer, the scientific community has yet to recognize the association between corneal ulcer and lacrimal duct obstruction or dacrocystitis. And the take-home message for this is, while treating the corneal ulcer, please assess the blockage of the lacrimal duct. These are the references. Thank you.
So one question, sir. There is another way out that corneal ulcer is a cause of chronic
dacrocystitis. That is a
dacrocystitis.
popular belief.
Okay.
My study is again.
And usually what we say to the patient that when you have a dacrocystitis, you may have a corneal ulcer. Is there any supporting evidence?
That is popular belief. If you have corneal ulcer, if you have dacrocystitis, you have corneal ulcer. But here is against them.
Okay. So in the mean, that marks the end of this session. In the meantime, we can take question. I will request all faculties to come forward and chairpersons to stay so that we can have a photograph. Thank you. We will have an inauguration at first, and then have a